Hi, my name is Kelly Snyder. I did my disease process paper on pulmonary hypertension, and this is my poster presentation on it. Just a little side note before I get into the disease. The colors for its awareness is purple, so my poster is done in that, and then also there's a picture of a zebra on the poster, and that's just representing that sometimes people can mistaken pulmonary hypertension for something else, so they use the zebra kind of as its spokes animal. But pulmonary hypertension can be defined as pulmonary artery pressure that exceeds 25 milligrams of mercury at rest, 30 milligrams of mercury with exercise, in association with a pulmonary capillary wedge pressure of greater than 15 milligrams of mercury. It is also used to calculate the pulmonary vascular resistance that's greater than 3 milligrams of mercury. So what does this all mean? It just means that there's an elevated blood pressure somewhere in the pulmonary system. Some facts on it is the incidence of pulmonary hypertension is 2.4 million cases per year, with the prevalence of 15 cases per million. Pulmonary hypertension can be diagnosed at any age, but the average age of being diagnosed is 50, and 60% of the people who have it are comprised of women. The classifications of it, primary pulmonary hypertension or idiopathic pulmonary hypertension was introduced in the 1950s just to categorize any patient who had an elevation in pulmonary artery pressure without an associated cause. Then you have your secondary pulmonary hypertension, which that's related to something else is causing it. So a lot of times, people with congenital heart defects, such as atrial septal defects or ventricular septal defects, that could be causing the elevation in the heart defects. Sometimes too, people with Down syndrome, their pulmonary arteries tend to be smaller, so they're more prone to having pulmonary hypertension. And finally, you can categorize it as a familiar link. Complications of pulmonary hypertension, it can cause heart failure. Typically, it will start in the right-sided heart and then actually progress into left-sided heart failure. You can have pulmonary hemorrhage just from the congestion of blood in the lungs, and death is also a complication of it. The pathogenesis of it, there's a number of different causes. There's not really a direct cause of why people think that they get idiopathic or pulmonary hypertension. Some research has come out in the past few years that kind of give a possibility. They think a lot of it has to do with the endothelial cells in the vascular lining and the smooth muscle. Some people think that there's a lack of prostacyclin. And what that does, it's used as a platelet aggregate, but it also is known to dilate pulmonary circulation. So people think that they might be lacking nitric oxide. Nitric oxide is a very, very potent vasodilator, especially in the pulmonary vessels. And people also think that there could be an excess amount of endothelin-1, which is a potent vasoconstrictor. But the thing that is actually surprising are the pulmonary arteries are thin-walled, but the distal arteries have the capacity to dilate or collapse and constrict depending on the presence of different substances that could cause vasoaction. So that's why they think that these components could have an effect on the endothelial cells. The secondary pulmonary hypertension, I kind of touched on it a little bit when I did the classification, but when you have the second cause, you have increased pulmonary blood flow through the left to right shunts of the heart, or the congenital heart disease, like the atrial or ventricular septal defects. And the high flow causes morphological changes in the pulmonary vessel, causing the pulmonary hypertension. The familiar link, it tends to be an autosomal dominant trait with a variable but low penetration that is responsible for the cause of the pulmonary hypertension. So there's various clinical manifestations that go along with the disease. A lot of them can be mistaken for something else, a respiratory disease like asthma or COPD or emphysema. But they're usually dyspnea on exertion, fatigue, chest pain, syncope, palpitations, lower extremity edema, clubbing of the fingers. Their breath sounds could be decreased. You could hear rales. They may have a productive cough. When you listen to the heart sounds, you may hear a new onset murmur. And depending on how the disease is progressing, you may even hear a gallop at times. Sometimes, depending on how progressed the disease has gotten, You may see splenomegaly, ascites. A lot of times these patients do develop pulmonary effusions. So how do you diagnose this? The first basic thing, as any clinician, you would do a head-to-toe assessment. You want to listen to their lung sounds, you want to listen to their heart sounds, you want to check for the presence of the clubbing, check their perfusion, look for the edema, check to see if their abdomen is distended, looking for ascites, looking for hepatomegaly, which could also be possible. One of the gold standards of diagnosing pulmonary hypertension would be to do a heart catheterization, where they can do a pulmonary hypertension study, where they're going to measure the pulmonary capillary wedge pressure, they're going to measure the pulmonary vascular resistance, and they're also going to be able to measure the pulmonary artery pressures. So they're going to be able to see what affects that. Other things that people can do are just a chest x-ray, and that can also determine, is there something that's causing a pulmonary hypertension. Sometimes you can see, abnormalities with the heart, you can see abnormalities with the liver, the spleen, things of that sort. Another standard is an echocardiogram. You can actually read a pulmonary pressure on an echo, but also an echo, you're looking for those right to left shunts, or the left to right shunts, that could be causing the pulmonary artery hypertension. A lung perfusion scan could be done, and that's just checking to see, is blood being perfused to all parts of the lungs. If there's not blood being perfused to all parts, is it backing up and causing the increased pressure? You do a chest CT, pulmonary function test, just to rule out any other lung abnormalities that could be causing the pulmonary hypertension, which is like COPD, emphysema, things of that sort. There's also some labs that can be done. There's no actual lab that can diagnose pulmonary hypertension, but there's tests that you can do to test for other things that could potentially cause increased pressure. You could look at the liver functions to see if there's any abnormalities in the liver. An HIV test could be done, and you can also test for autoimmune disorders. Treatments for pulmonary hypertension, there really is no cure but there's some things that you can do to alleviate the person and help bring down the pulmonary hypertension. The first thing is oxygen. Oxygen seems so simple and so mundane, but it can actually act as a vasodilator. You can dilate the pulmonary arteries to decrease the pressures in them. There's other invasive options that can be done. One of them is called an atrial septostomy. It's actually a very cool procedure to actually see being done. It's done in the cath lab, and they actually will go in through the groin and make a right to left shunt in the atrius to make atrial connection to shunt the blood away from the lungs, so you have a right to left shunt. I've seen it in kids with congenital heart defects, mostly the transposition patients, to bridge them to surgery, but in pulmonary hypertension patients, that's something that can alleviate. It's a palliative treatment, so it's by no means a cure, but it can help alleviate some of the symptoms that the pulmonary hypertension is bringing on. Another surgical option that is done is called a pulmonary thromboendarterectomy, and this is a procedure done in the operating room via a median sternotomy, and you do put on bypass and all that goes along with that. But what that does, it's aiming to reduce the pulmonary artery pressures, hopefully to normal, or close to normal as what they can. Ideally, they would like this to be a curative procedure, but a lot of times it's not. And one option that is always available for these patients, and usually is a big necessity to a lot of them, is transplant. The timing of the transplant depends on the severity of the disease. It depends on the stage of the disease, if the patient is responding to conventional therapies, and there's really no alternative. A lot of times these kids also have, or these patients have to, looking at the timing of the donors, is this the right time? Some people will put off transplant as long as they can, just because lungs typically only last around 7 to 10 years, so they want to try and give them as much time as they possibly can. There are some medications that patients can take to help treat pulmonary hypertension. One of them is called sildenafil. Most people know this drug as treatment for erectile dysfunction, basically Viagra. And it is a pulmonary vasodilator, so it does decrease the PA pressures. It does have some complications to it. It does, or some side effects. It does cause chest pain. It can cause hypotension, dizziness, and cause sensitivity to light. And also, it does cause erections. So for some people, that may be an issue. Another medication that is also used, and in my experience with it, it's probably one of the scariest medications to have a patient on. It's called Flolan. It's a potent vasodilator. It's administered as a continuous infusion, typically through a central line. It can go peripherally. But the scary thing is when a patient is on this, they are dependent on it. It can't be interrupted. You have to stay on it. If a patient runs out and they don't get it within seconds, it could be life-threatening. And it has a half-life of about 3 to 5 minutes. So they start feeling that it's not there almost immediately. It can be costly. The research I did, it can cost up to $100,000 a year to be on this medication. You also have to keep this medication cool. So the way it's administered through a CAD pump, and the patient has to have 2 ice packs on it at all times to keep the medication cool. It can cause facial flushing, headache, jaw pain, abdominal cramping, diarrhea, tachycardia, hypotension, chest pain, and generalized muscle pain. I just had a patient recently who received a double lung transplant because he had severe primary pulmonary hypertension, and I couldn't get over the fact of how flushed he was from the Flolan and how vasodilated this medication caused him. And afterwards, he looked like a completely different patient. It's a very cool drug, but it's a very, very scary drug to have a patient on because you constantly have to have a backup, constantly be monitoring that site to make sure that that patient is getting that drug. Some nursing implications. As nurses, we can't prevent pulmonary hypertension from happening. If it's going to happen, it's going to happen. But what we can do is help the patient to maintain optimal function. So just making sure that they're not progressing, making sure that they have optimal cardiac function, optimal respiratory function, notifying the appropriate physicians if you see them kind of progressing and getting worse, so if they're developing more edema, if they have an increased use of oxygen, just kind of let the doctors know. Helping them to cope is a big thing because this is a progressive disease. It's only going to get worse. It's not going to get better. It's helping them to cope with their disease, talking to them. Normalization is a big thing because some of these patients, you can be diagnosed with pulmonary hypertension, as soon as you're born. Helping to keep them having a normal life and promoting that normal life and doing whatever you can to bring in normalization to your care. And sometimes that does involve end-of-life care. And it could, be the nurse talking about advanced directives when it's the right time to do it and not when it's too late. Also, just, preparing them, if they're on the road to transplant, preparing them for transplant, because transplant can be a little traumatic for some patients, and helping them to understand, what to cope with and what to expect when, they come out. So in conclusion, pulmonary hypertension is a chronic, progressive disease. It has, various causes, various classifications. It can be treated with different medications such as the Flolan, sildenafil. There's different invasive procedures that can be done. It can be treated with oxygen. Transplant's always an option for people who have pulmonary hypertension, and as nurses, just to treat the patient and keep them as comfortable as possibly can. These are my references. If you have any additional, if you'd like any additional information, feel free to contact me. My name is Kelly Knox-Snyder. I'm a student at Mount Aloysius College. My email is kmkst9@student.mountallo.edu. Thank you.